Our next guest, Pat Hirsch, is a nurse with extensive experience in critical care units and in PACU units, and is also very familiar with electronic medical records, specifically the Epic system. She's going to share with us some of the common types of liability that affect nursing and nursing care in the PACU. Pat, welcome to the show.
Thank you.
We will start, first of all, focusing on falls. I know as a med-surg nurse and as a person who used to review PACU cases as well, I can think of people who fell in the PACU and ended up injuring themselves pretty significantly. One woman who had foot surgery and put all of her weight on her bad foot because she got off the stretcher without asking for help, and somebody else who fell in the bathroom. Those immediately come to my mind. As we are looking at cases involving falls in PACU, what should we be looking for in terms of seeing if the nurses considered them to be high risk for falls?
Our patients are all screened in pre-op, or when they come in through the emergency room, or if we get the patients from the floor, they should have been screened already as a fall risk. In our health system, we use the Morse fall scale, and that determines from a series of questions or subjectively looking at the patient as to you making that decision as to whether the patient's a high fall risk or not. And in general, any patient receiving any kind of sedation or anesthesia or pain medicine is considered a fall risk. So the scale focuses on asking the patient if they had a history of falling in the last 3 months, if they have a history of syncope, dizziness, if they're on multiple medications, if they use assistive devices such as a wheelchair, a cane, walker, or crutches at home, if they have peripheral neuropathy, because that definitely could affect them falling. Other markers are if they have bone-related problems, such as fractures, or a patient who has cancer and has bone meds. So what we do is that's how we come up with a scale that determines if they're a low risk, a medium risk, or a high risk fall patient. In our institution, we use a yellow bracelet and the yellow grip socks to identify the patient as a high risk fall patient. And that way, any team member who sees that patient up and about, or trying to crawl out of bed, or you walk by a bay where there's curtains and you see yellow socks and nobody with them, you know to go assist that patient. Another area is visual disturbances. We do have blind patients or patients who have problems with double vision, vertigo. And another one, big one, is patients who don't speak our language. We do have interpreters at the bedsides at all time, or if we don't have a live interpreter, we do have an iPad that we use as like a nurse interpreter line. So that's really important, just so the patient does understand when you tell them, please don't get up by yourself. So also all surgical candidates who are having a total knee, total hip replacement, and get nerve blocks or any kind of surgery in the lower extremities, it requires a nerve block where the patient, it actually numbs the whole leg, they are absolutely at a high fall risk.
Yes, I could see how that would happen. I can think of people who've had total knee replacements who have fallen after surgery and disrupted the hardware.
It does happen.
Happy with that.
Absolutely does happen.
Yeah.
Yeah. Another area too, Pat, patients who might have surgery like an open inguinal hernia repair or any kind of surgery in the groin areas, like lymph node biopsies, where the surgeon might numb up the area, that can also numb your leg. And when that happens, we do check the patients for their strength while they're laying in bed. And also, we do use two nurses to get the patient to stand up because we have had a patient go down who seemed totally fine, had a strong, um, they had a strong legs when we were testing them, like pushing their toes against our hands. And this one gentleman I remember did go down, and we did not expect it at all.
Mm-hmm. You've mentioned some measures that can be taken to prevent falls. You mentioned the yellow socks, you mentioned use of an interpreter, you mentioned having two people involved in assisting the patient when it looks like it's warranted. Are there some other measures that the standard of care requires that we should be following to prevent falls in the PACU area?
Absolutely. Side rails up at all times. Have the bed in a low position, brakes on. The floor should be clear of clutter. Have the call bell within reach at all times. If you have a confused patient, you always want a family member or somebody there with them at all times. I encourage people to put their glasses on, their hearing aids in, so they can hear us. Um, and it's also practice in our facility that patients cannot be alone to get dressed. We must help them get dressed. If they go to the bathroom, we must assist them in the bathroom. Ones that can't walk, we'll use a wheelchair to take them to the bathroom, or we have this device called a Sarah Steady, which is pretty cool. They stand on this device and you kind of push it right into the bathroom. Another one is our total knee and total hip replacements. Now they are sending them home same day. So we have physical therapy actually come into the PACU. They do physical therapy with them. They assess whether they feel that the patient is able to go home, because most of these patients, well, not most, but probably about 50% of them get spinal anesthesia as well as a general. And the spinal pretty much needs to be worn off, and the patient needs to be able to void before we can allow them to go home. And they also need to be assessed by the physical therapist to determine if they're able to walk a couple steps. We have a small stair system on the side of our PACU. And, if they don't feel like they're ready to go home, then we will admit the patient.
Wow. So somebody who's had a total knee or a total hip replacement is bearing weight on the extremity in the PACU on the stairs?
They can be, once that local wears, or once the spinal wears off, because they also get a nerve block with it. So they do, it's not, the leg isn't totally numb. They only
Mm-hmm.
pretty an abductor nerve block, so it's only part of the leg is numb, so they can still feel. Yeah, it happens. This is our century now.
Let it be known that I'm not going to have a total hip or a total replacement of my knee done at any point in my life. I'm putting this on record right now. I do not want to put weight on my leg in the PACU. Thank you very much, Pat, for that concept. Cross that one off the list.
Yeah, I get it. I totally get it.
Oof.
Yeah.
All right, let me refocus because I have to get over the horror of that idea and think about what else can go wrong in the PACU now that we're on this cheery subject of ambulation within hours after a total joint replacement.
Mm-hmm.
The airway. Uh,
Yes.
Big problems when we have disruptions of airway. What are some of the warning signs that PACU nurses are trained to watch for?
Of course, the number one thing is when they're coming right into PACU, you're going to look at their color, because that tells you a lot about the patient. Also, the breathing. Um, we hook them up to the monitor if they're hypoxic, or if they have stridor, have any kind of wheezing. We know how to treat those problems. Let me just focus on a pediatrics, because we do pediatrics. They do have a high risk of respiratory problems, so you administer oxygen as needed. If they do have any kind of wheezing, stridor, we do get respiratory therapy and get some treatments for them, such as racemic epi or albuterol handheld nebulizers that we actually use a face mask with them. In the other patients, specifically high CO2 levels. We see those in COPD patients, lung restrictive patients, your obstructive sleep apnea patients. Sometimes you can see them in patients who have had like a robotic or laparoscopic procedure and they have COPD on top of that because you're filling up that whole cavity in the belly with CO2. And if they're not able to expel a lot of that, they hold on to that. And that can really take up the CO2 levels in the patient. So we do use CO2 monitoring or capnography in the recovery room.
And is that attached to a nasal cannula? Is it attached to a mask or something else?
Ours is, yes, we do have a nasal cannula, and we have a little port to the cannula that hooks right into the monitor, and that will tell us what the CO2 levels are. If a patient is also on a PCA, it's mandatory that they have a CO2 monitoring, and actually that's built right into our PCA.
One of the things that comes up, Pat, is that we're checking oxygen levels with the pulse ox, and the pulse ox machine is not infallible. I've been involved in a few cases where the pulse ox machine was judged to be not working properly, and yet it was. The patient's oxygen level was really low and trending downward, but the PACU nurses thought that the machine was malfunctioning. Can you take us through what kind of troubleshooting you would expect a PACU nurse to see or to do when the pulse ox reading is getting concerning and the nurse is doubting whether this is actually indicating a problem?
Well, obviously you got to look at the patient. I think that's the number one thing. Does the patient exhibit the symptom look like what you see the oxygen level to be? So we give supplemental oxygen. If sometimes your sleep apnea patients or COPD patients, sometimes just repositioning them is enough to bring that oxygen up, sitting them up, doing a chin lift or a jaw thrust. Sometimes patients come out with oral airways or intubated. If they're still kind of obtunded and they're lethargic and you need to put an oral airway in, we can do that. Or else a nasal trumpet. That's a great one for airways as well. Suctioning. Sometimes patients just need some oral suction or a little tracheal suctioning. CPAP, BiPAP. If the patient is on CPAP at home, we have them bring it in, or a BiPAP. Sometimes that alone will just help if they're real sedated to bring that up. Sometimes really oversedated patients, if you can't figure out what's going on, their sats aren't coming up, you're giving them oxygen, sometimes you need to give them a little bit of Narcan. Or if they're IV sedation and they get Versed, you can give them the Romazicon for that. Sometimes it's not, we don't do this, but the anesthesiologist does it, or the CRNA is reversible muscle relaxant. If they're just totally too relaxed, their tongue keeps falling back. And lastly, you don't want to have to do this. If you have to do it, we do it, is reintubation.
Mm-hmm.
The big thing, if the patient is awake and their sats start dropping, have them cough, deep breathe, try to stay calm because it's terrifying if you can't breathe. That's, try to reposition them to get them comfortable. Still, it's not happening. And the patient had no complications in surgery. Sometimes you just, of course, listen to the lungs. If you notice any rails, crackles, then maybe you need to get a chest x-ray to see what's going on.
How readily available are anesthesiologists to write these kinds of orders and to respond to these concerning signs? Before we continue with the show, I'd like to share this special announcement with you. Did you know that teaching attorneys and making sales presentations have more in common than you might think? On the surface, it might seem that giving a presentation before a group of lawyers to talk about what an LNC does is very different than making a sales presentation. Consider, though, these common factors. You're the center of attention. You must speak well. You must present yourself well. You must be able to answer questions quickly and easily. You must appear calm and self-assured. I'm Pat Iyer. My new book on this topic is Powerful LNC Presentations: How to Get the Case. This book prepares you to master the steps of both educational and sales presentations. Whether you're seeking chances to teach attorneys or invitations to make a sales presentation, this book gives you the framework for excelling in both situations. You'll learn the strategies for seeking speaking opportunities, those wonderful experiences that put you in front of your ideal client. Once you have a speaking opportunity, focus on how to make in-person and online presentations for attorneys engaging. Part 2 of the book changes the focus to sales presentations. You've made a solid educational presentation to an attorney, and now they want to discuss a case with you. The second part of this book gives you the tips to confidently master a sales presentation. I built a multi-million-dollar independent LNC practice gained from my experiences by mastering the content of this book. Powerful LNC Presentations: How to Get the Case will guide you through 2 key elements of an LNC's business: attracting prospects and winning their business. Order it today at lnc.tips/creating series. Now let's return to the show.
In our facility, they're pretty good. They're right. They're very available to us. We're in a huge hospital, so it's pretty easy for us to get hold of them. If a patient comes out from, the operating room, and obviously if there's a bunch of people with them, something's going on, they stay with the patient until they are stable or you feel they need further intervention. If someone's in CHF, we give Lasix. That doesn't happen too often, but if they need some kind of IV intervention with, diuretics, we do that.
So let's assume that Dr. Jones is the anesthesiologist on the case and has brought the patient back, and you're an hour and a half into the recovery and you start seeing signs that concern you, and the anesthesiologist is now working on a different case. Can you get to that person who did the anesthesia, or do you grab anyone who is available and ask for help?
In our facility, we have an anesthesiologist who's in charge of the ORs, and therefore he or she does not take a patient. We have CRNAs, or there might be other anesthesiologists there as well. So they're pretty much available to us if someone's available to us at all times.
Got it. All right. That's reassuring.
Oh, it's great. It's a great thing at our place.
And if we think again about complications, one of the most dreaded complications in the way that LNCs evaluate these cases is somebody is quietly bleeding internally
Mhm.
after being transferred out of the OR and is in the recovery room area and is quietly bleeding. There's no necessarily respiratory symptoms. There may not be a change in level of consciousness. Tell us about the thought process for a PACU nurse who should be considering bleeding as one of the things that are going on. What are the warning signs that you as PACU nurses are trained to pay attention to? And what do you do when that happens?
Um, First thing is when you get the report, of course, from the ORs to see how much the EVL was, if the patient required any kind of albumin or any kind of fluid resuscitation during the procedure. Me personally, I look at the color of the patient coming out, the neurostatus of the patient when you hook them up to the monitor, tachycardic. Why are they tachycardic? Are they tachycardic because of the anesthesia coming off? Are they hypotensive? If you have hypotension and tachycardia, that kind of gives you a clue that something might be going on. Looking at the wound sites, all the dressings, check those out, see if there's any bleeding. If so, um, best to take a marker and circle it, and I also time it so you can see if the bleeding progresses outside of that marked area. Check if they have like a laparoscopic or robotic site, check all the trocar sites, see if there's redness, if there's swelling like hematomas that are forming underneath them. Stomach surgeries, if it becomes extremely tender, if the patient's awake, you're giving them pain medicine, but nothing seems to be helping them. And despite using ice, repositioning, giving pain medicine, and their belly is getting taut, you might see some ecchymotic areas. That's a big, big sign there might be some bleeding going on. Blood pressure dropping, and also they start getting just not feeling right, dizzy, headache, or their oxygen starts dropping. If they get hypotensive, you might have to put them in Trendelenburg position, give them oxygen, fluids. The best thing to do is notify the surgeon right away, notify anesthesia in case there's going to be further intervention as an intubating or, things can crump really quick. Also, if they have any surgical drains, you want to assess those, see if there's excessive bleeding coming out of those. There is one case I can remember. We had a hysterectomy patient. She was fine, getting ready to go home, and she sat up and she was so pale, sweaty, and was passed out. We kind of threw her down to the cart again, and she had a bleed,
Mm.
and we had to take her back to the OR. So in that instance, most patients are type and screened. That's one thing you really want to do, get a type and screen, CBC, and also throw in an extra IV, like at least a 20 gauge, 20 or 18 gauge, another site. So you have another site in case, when they go back to the OR, you need to be giving blood, platelets, anything, any kind of blood products.
Those are all wonderful aspects of being prepared to handle that crisis. If you were coming into work and one of your colleagues pulled you aside and told you about an incident or a crisis that was occurring in the PACU, what do you find to be most frightening as a PACU nurse to think about having to deal with?
Um, Kids are scary.
Kids are scary. All right. What aspect of them makes them scary for you?
I love kids. thing with kids is respiratory. When they have respiratory problems, things can go sour. Um, I have never really witnessed anything really bad. Um, but that scares me. Just sometimes it's really scary too if something's going on. You just don't know. You just don't know what's going on with the patient. You know, if something happened to the patient because with anesthesia, especially your elderly, they can get real confused and you're trying to figure things out. One thing that we found, we do use scopolamine patches. I don't know if you've ever used them, Pat, but they have side effects. And sometimes patients are very, very sleepy. And if they're not waking up and they have one on, we kind of think of that, oh, we'll take that off. And we take it off, and within 20 minutes, if they're waking up, that's what it was. It's really interesting.
My association with scopolamine is when it was given to women who were in labor and it made them loopy. That was
Mhm.
in the era when I was in nursing school. And I had an instructor who gave me a very hard time as a student one time. And within a year, she was pregnant and she was delivering in our labor and delivery unit, and she was out of her mind. And I
Mhm.
have to say, it gave me just a small amount of pleasure to watch her hallucinate. She believed that she was on the back of a car and she recognized the lead OB instructor and said, Janet, what are you doing in this car? And Janet said, I'm driving this car. That's what I'm doing. So I remember very clearly. It, of course, it stopped. It was terrible for the whole concept, which later evolved, that women should be awake so they can participate in and enjoy their labor, or at least to enjoy the fact that it gets over. But turning them into raving, hallucinating women was not necessarily consistent with good, sound patient care.
True.
So, so I have a whole different association with scopolamine, and it was given IV, as I recall, and not in a patch form at that point.
Yeah, it's a quick fix. You just take it off, and about 20 minutes later, it seems like patients kind of come around. So, but another really scary, I was just thinking about this. Probably when this scary thing is positive pressure pulmonary edema. It's kind of
Mhm.
like, you know what I'm talking about? It's kind of like when a patient comes out, it usually happens in young, healthy patients. And it's kind of, they kind of go, and then it just forces you get backflow into the heart, and they end up going into pulmonary edema.
Hmm.
They, we used to treat it with Lasix, and of course, like, you know, oxygen, get chest x-rays, set them up. And sometimes you got to put a Foley in because, you know, Lasix and their Disnic. And now the theory is to kind of let it ride out as long as it's safe. Um, and the patients will be in PACU longer, or if needed, they'll admit them. But that's kind of scary if you've never seen that before.
And I would think, especially if it's happening to young, healthy patients, it would be very unexpected in the clinical picture.
Correct. Very, yes.
And what
Yes.
causes this?
It's kind of like when there's positive pressure, when they like up through here, where they go like that, and it kind of like puts pressure with it backflows, um, makes your lungs fill up with
Mm.
fluid. It's very scary. It's
Hmm.
I've seen it twice in my career so far, and I had no idea. I didn't understand what was going on until the anesthesiologist, you know, explained it to me. And you know, once you see it once, you're more prepared to take care of it again.
Yes. I think after this conversation, people who have watched your presentation will be thinking about PACU in a little bit of a different light, recognizing the risks, the dangers, associated with recovering from anesthesia, the constant vigilance that is required on the part of the staff,
Mhm.
looking at equipment and recognizing that you could be looking at an equipment failure, or you could be looking at a clinical change in the patient that's causing those numbers to look very odd and unexpected. There's lots to consider.
Mhm. It's a good challenge.
It certainly would be.
Mm.
I know that there'll be people who are going to hear this program on our audio channels or watch it on our YouTube channel of Legal Nurse Business who will want to know how to reach you, Pat. What would be the best way for them to do that?
I am on LinkedIn, Trisha Hirsch, Hirsch, or by email, pat at Hirsch, Hirsch, LNC.com.
All right. And Pat is a PACU expert witness who reviews cases for both the plaintiff and the defense. She's currently working in the clinical area, would be a great person for you to consult with if you've got a PACU case and you need to have a standard of care expert, or you need some behind the scenes consulting. Keep her in mind. Thank you so much, Pat, for being a guest on Legal Nurse Podcast.
Thanks for having me, Pat.
And for you who's watching this program or listening to the program, tell another legal nurse consultant about Legal Nurse Podcast so that they have the benefit of the shows that we release every Monday. We also have on our website at podcast.legalnursebusiness.com, there are podcast bundles available to you, and we just refreshed those a little while ago. There are 6 categories of topics and 4 podcasts in each bundle. They are the best of the best in that category based on the most number of people who listened to those podcasts. And that's free for you to check out. You can get all 6 bundles, you can get one of them and go through those podcasts and get the benefit of the tips that we share. Be sure to come back next show for a new guest, new topic. This has been Pat Iyer with Legal Nurse Podcast, talking with Pat Hirsch about PACU risks, liabilities, and challenges. Thanks so much. This is Pat Iyer with Legal Nurse Podcast. Coming up next, we are taking you behind the closed door, behind the curtains, into the PACU with our next guest, Pat Hirsch. She is clinically working, clinically active, and shared with me in her show some of the hot topics, high-risk aspects of working in a recovery room, post-anesthesia care unit, or PACU. Pat, what were some of the topics that we covered in your show?
We talked about liability issues in the PACU with a focus on patient falls. We talked about risk factors of falls and ways to identify patients who are high risk for falls. We talked about airway disruption, how to assess patients, and treatments for problems with airway problems, and also bleeding in the PACU, how to identify signs and symptoms of bleeding and what intervention is. And also, we talked about crisis nightmares in the PACU, um, things that can go wrong, that have gone wrong, and things that scare you.
And if you hadn't considered some of these clinical crises before, by the time you finish watching Pat's podcast, it will give you a greater appreciation for the risks and the challenges of working in this critical care environment. Be sure to come back and watch Pat Hirsch's podcast on PACU challenges. Thanks so much. Coming up next on Legal Nurse Podcast, you'll have an opportunity to meet Camille Ranella, who is a nurse. She is a former associate faculty member of the McLean Center for Clinical Medical Ethics at University of Chicago, also where she earned her postdoctoral fellowship in clinical medical ethics. Camille, what were some of the topics that we covered in your podcast?
And I'm also a legal nurse consultant. Don't forget that part too, so I can put it all together.
All right.
In my podcast, what we talked about briefly is what is the difference between law and ethics regarding objectivity? You know, what makes them different? We talked about the Joint Commission requirements for ethics committee members, which we said were no standardized requirements at this time. We talked about the kind of preparation that ethics committees members get to prepare them for their role. And again, there's no formal preparation and orientation. I did give some examples and told a story about a situation, or actually a couple situations that Pat and I talked about, where when a legal nurse consultant contacted me about a case involving discovering the background of ethics committee members and how that influenced their review of their specific case. We talked about the difference between nursing ethics and medical ethics and clinical medical ethics. We also tried to focus in more clearly on the job of an ethicist, especially a clinical medical ethicist. And I went kind of extensively into this because not everybody's really sure about what we do, and that we are trained and educated at a very high level around specific objective standard medical ethical principles. So it's not subjective. This is very core objective principles that we base our practice on. We talked about listening to your gut feeling and the value of that. And then I also suggested that the viewers look at our website at healthcare competency program specialists, and that they would click on what would you do on our website at the top of the page, so that there's more of an understanding and practice of what you know and what you don't know.
All right. You can see that we covered a lot of territory in Camille's podcast. Be sure to tune in for the next show. You'll have an opportunity to get some of the answers to those questions that I asked of Camille, and think about ethics as they relate to your practice as a healthcare practitioner, as a business owner, as a legal nurse consultant, all of those intertwined. Thanks so much. Be sure to get Camille Ranella's podcast. Bye-bye.
Thank you.